Hi, I'm Miriam Weinstein, and thank you for joining me for The Root of the Problem, an approach to the diagnosis and management of hair loss disorders in children. I have no disclosures over the last 12 months, and I do intend to talk about some off-label uses of medication. What I hope you'll get by the end of this lecture is an ability to identify the different patterns of presentation of hair loss in children, be able to initiate a workup to confirm the diagnosis and rule out other causes where indicated, and identify management strategies where relevant for the most common causes of hair loss in children. The practice change is a little bit more specific, and as a result of this session, the learner will be able to make the following practice change: ensure a culture for confirmation of diagnosis of tinea capitis, and that oral therapy is really the treatment of choice for tinea capitis. Just a little bit of an outline. I'd like to briefly talk about the hair cycle, as some of the hair loss disorders will relate to an understanding of the hair cycle. I'd like to do an overview of hair and scalp disorders and where they intersect. There are some conditions where both scalp and hair are involved. And then I want to talk about approaches to hair loss in children. There's several different ways of doing it, and I'm going to present what I hope is a very practical approach for you to use in clinical practice. And then we'll talk specifically about the hair loss disorders, and I'm going to focus on the 5 most common hair loss disorders in children, and then we'll come back to the approach and look at that in a little more detail. Let's start with the hair cycle. So growth and shedding of hair occurs in cycles. The first phase is called anagen, and that's the growth phase. And for scalp hair, this can last for between about 2 to 7 years. And that's what allows our hair to get so long on the scalp. In other body parts, for example, the axilla, eyelashes, or eyebrows, that anagen phase is much shorter. And that's why those are areas of the body that don't ultimately grow hair beyond a certain point. Each hair is on its own timetable. If all of our hair follicles were on the same cycle, we would alternate between complete shedding of our entire hair and then regrowth. And there are animals that do manifest that pattern, but we don't. Our hairs are on different cycles, although some of them certainly align on the same growth and shedding cycle. Catagen is the next phase, and that's a transition phase that can last about 2 to 3 weeks. And this is where the hair starts to shorten and loosen from the hair follicle to which it's attached. Telogen is where this broken off hair rests for about 3 months before it actually gets shed. And the number of hairs that get converted from anagen through catagen to telogen can be impacted by various disease or stress states, and we'll talk a little bit about that. But normally at any one point in time, about 10 to 15% of hairs are in telogen. And finally, exogen is when the hair is actually shed. And a new hair starts to emerge, not necessarily through the scalp, but at the base of the hair follicle, ultimately to come through the scalp. And on any given day, we lose between about 50 to 150 hairs per day. This, of course, will be increased if the number of hairs in telogen prior to exogen was increased. If we look at this pictorially, you can see that anagen, the hair is fairly tightly attached to the hair follicle. It starts to loosen in catagen, and then in telogen, the new hair is just starting to emerge as this hair is resting just before it's shed, as the new hair is growing in a little bit longer at that point, ultimately to emerge through the scalp. If we look at hair loss disorders, they can include a variety of conditions, which we'll talk about, but we can also look at scalp disorders. And there is a little bit of overlap, but they're often different conditions. In hair loss disorders, we would consider alopecia areata, telogen effluvium, trichotillomania, although really trichotillomania is often a manifestation of stress or a behavioral habit rather than a primary hair problem, but it does present as hair loss, and thus it's classified this way for the purposes of this lecture. Traction alopecia and androgenetic alopecia. Hair shaft abnormalities are a very rare group of disorders, but I think it's important to at least have it on your radar and know that they exist. And this can be, in some cases, actual genetic abnormalities of the keratin, which is the most important structural protein of the hair. And there's also some hair shaft disorders that we know have an abnormality. We can see the hair shaft abnormality under the microscope, but we don't know the particular genetic cause of that, or if in fact it is genetic versus random. Some scalp disorders, common scalp disorders, can include psoriasis, seborrheic dermatitis, retention hyperkeratosis, which is just retained dead skin cells, atopic dermatitis, and allergic contact dermatitis. For example, some hair dyes with darker pigments can rarely cause an allergic contact dermatitis. I think it's important to know that classically the scalp disorders don't routinely lead to hair loss as part of the disease, but can in a secondary way. So for example, atopic dermatitis does not affect the hair and doesn't lead directly to hair loss. But some patients who scratch or rub their scalp a lot because there's atopic dermatitis on the scalp will subsequently, due to friction, end up getting a loss of their hair. Lice is typically a disorder of the scalp. Again, it could secondarily lead to hair loss through rubbing and scratching, but this is a condition where you're going to see, as most of you know, excoriations, pruritus, and you can actually see, in some cases, the actual nits and lice. But it doesn't actually cause the hair to fall out directly. Again, it's usually through secondary friction. And finally, tinea capitis is a common cause of hair loss, although sometimes it only affects the scalp without hair loss, such as increased scaliness or pruritus. So we put that one in the middle. In addition to examining the scalp and the hair when assessing a patient for hair loss, there are some other things to consider on physical exam. We always want to check the lymph nodes, including the occipital, post-auricular, and the cervical chains. That sometimes can help us make a diagnosis. In particular, we tend to see significant adenopathy in tinea capitis. We want to see if there's skin disease elsewhere. A patient who has a scaly scalp, it can be very difficult to tell apart tinea capitis from psoriasis, from eczema. While there are some subtle features that distinguish them, oftentimes they can look exactly the same. If, however, the patient has the particular condition elsewhere on the body, it's often much more morphologically distinct. For example, eczema and psoriasis look very different on the body. So if there's skin rash elsewhere, that might help actually make the diagnosis of what might be going on the scalp. However, some patients present only with scalp disorders, and then it can be more challenging. Nail changes can be seen in some of the hair loss disorders, and we'll talk about that. It's also important to look at dentition. In the rare cases of hair shaft abnormalities that I mentioned, they can be part sometimes of what's called an ectodermal dysplasia, where there's abnormalities of multiple different ectodermal derivatives, including the skin, the hair, the nails, and the teeth. And finally, we want to do a pubertal exam where relevant. Certain conditions, such as androgenetic alopecia, may be a part of typical puberty for males and sometimes females, but if you were to see a pattern of androgenetic alopecia pre-pubertally, there may be a concern for a hyperandrogen state, and it might require more workup. There's different ways of approaching hair loss. One common one is to look at scarring alopecia versus non-scarring alopecia. Another way is to look at inflammatory hair loss disorders versus non-inflammatory. A third way would be to look at congenital versus acquired, and these are all common approaches that people use. But what I'm going to focus on for the rest of our lecture today is really a practical approach. And that's because patients don't particularly come in and say, I've got scarring or not scarring. They come in presenting with hair loss. And that hair loss can have 4 main different patterns. And I find that to be a more useful starting point. So let's take a look at that. The 4 categories that I tend to group this into is, first of all, poor growth or abnormal texture or easy breakage. So these are things that suggest the hair just can't maintain its integrity or doesn't grow very well. The second category is increased shedding. So the patient notices more hair coming out. The third category is they may or may not recall an increased shedding phase, but they do see that their scalp has decreased hair density, or there's a generalized or localized thinness. And finally, actual bald patches. So let's take a look at that in a little bit more detail. We'll look at the four categories: abnormal growth or texture, and this can include breakage as well, increased shedding, increased thinning of the hair, or decreased density is the other way to look at that, and bald patches. So we can subdivide this. The next level would be with abnormal growth or texture of the hair follicle. We would sort of divide those into two different things, although they can have some crossover. For shedding, thinning, and bald patches, we tend to divide it between diffuse and localized. And in a couple of moments, we're going to talk about the most common causes of hair loss disorders in children, and then we're going to come back and look at this chart and try to look at some of those conditions and the way they present. So when we're finished, it's going to have the next layer, which I'll show you now, but we'll talk about that in a few moments. So this looks busy, but we'll get back to this. The 5 conditions I've listed at the bottom in green that are bolded, these are the 5 conditions that we're going to focus on: alopecia areata, androgenetic alopecia, tinea capitis, telogen effluvium, and trichotillomania. Let's start with alopecia areata. This is a common condition. About half of patients who end up with alopecia areata will present in childhood, and these are acute patches of hair loss, often presenting as a bald patch, although diffuse shedding or more diffuse thinning can be rarer presentations. Family history is positive in about 15% of patients, and this is thought to be an autoimmune condition where the immune system is attacking the hair follicle. And you've probably all seen these bald patches reasonably well circumscribed with alopecia areata. The scalp is normal. And again, sometimes hair shedding is what's actually noted early on. It can be any hair-bearing area on the body. Scalp is quite common, but eyelashes, eyebrows, and other body hair can occur as well. The exclamation mark hair are short hairs that taper as they approach the scalp, and these are classically known for alopecia areata, although many patients don't have them. So the lack of an exclamation hair does not preclude a diagnosis of alopecia areata. Interesting to note that when new hair comes in, whether it's spontaneously or we've used medicated strategies to grow the hair, new hair is often very fine and much lighter than the patient's natural hair color. Now, over time, the hair shafts thicken and the color darkens, and it blends right in with normal hair. There's several different patterns of alopecia areata. The first is patch alopecia, which is one or more round to oval discrete patches of hair loss. Oophiasis is more common in children, although still a rare pattern. And that's a pattern of a band between the ears at the occiput that has a band of hair loss. This has a probably poor prognosis and may be at higher risk of progressing to totalis or universalis. Reticular alopecia is areas of growth mixed with areas of loss. Diffuse alopecia is widespread thinning without an actual bald patch, and this is less common. Alopecia totalis is the total loss of scalp hair, and alopecia universalis is the total loss of all body hair. And this is an example of alopecia totalis. Here we see some lateral eyebrow loss, and here we see some patchy eyebrow loss. And this would be consistent with a reticular pattern where you see a mixture of both loss and growth. Alopecia areata can have sort of 2 groups of associated features. The first are the other autoimmune diseases. Like most autoimmune diseases, there can be an increased risk of having other associated autoimmune diseases over the lifetime. Hashimoto's thyroiditis is by far the most common, but other ones such as inflammatory bowel disease, vitiligo, celiac disease, Addison's, pernicious anemia, these are all possibilities, as is having a relative with an autoimmune condition. One study looked at the family history of thyroid disease in patients with alopecia areata versus controls and did find an increased incidence, and same for other autoimmune diseases as well. They looked at the patients in the study who had subclinical Hashimoto's thyroiditis, and interesting, in those patients, 75, so about 5% of patients had subclinical Hashimoto's, and of those patients, 75% had a positive family history of thyroid disease. So often the question that we have to contemplate is, once a diagnosis of alopecia areata is made, should we be doing screening for other autoimmune conditions and at a minimum thyroid disease? And I think there's literature that could really support either position, either doing that basic workup or not doing it, but rather screening the patient with routine good histories and physical exams at regular intervals, understanding that they do have an increased risk over time of that. The non-immune associated features are primarily the nail changes, and this can include nail pitting or longitudinal ridging known as trachyonychia. So this is pitting, where you actually see little indents or pits on the nails. But if you look at the nail, you'll see that it still has a shine to it, a luster, versus trachyonychia, which is longitudinal ridging, which also leads to a roughness of the nail and a loss of luster. The prognosis of alopecia areata is really quite variable and can be hard to predict. It does tend to be a variable disease with recurrent flares, although some patients do progress to total hair loss without the ability to regrow or without regrowth evident. Many patches can regrow spontaneously, so we do some treatments, which we'll talk about in a moment, but they're not always necessary. And the indication for treatment is primarily cosmesis, so treatment is always elective. Some potentially poor prognostic indicators would be a family history, other autoimmune conditions in that patient, a younger age of onset, extensive hair loss, the euphiasis pattern that, remember, goes from ear to ear along the occiput, and associated nail dystrophy. Let's look at the features or the components of alopecia areata management. The first, of course, is disease education. Patients always need to understand the condition. And this is a variable and recurrent condition where the goal of therapy is to try to regrow hair in the affected areas. It's unfortunately not at this point to cure the disease. And there's no real preventive measures. Treatment, unfortunately, is not always universally successful. Many patients want to know if stress plays a role, and it may, although that's not always something that can necessarily be associated in a given patient and may not alter the treatment strategies that we offer, other than if it's felt that there's a high level of stress that might have contributed to the onset of alopecia areata or a flare-up, or the results of having it are causing significant stress, then definitely counseling is warranted. There's some medical therapies, which we'll talk about, non-medical therapies, which can include wigs. Some people with eyelash or eyebrow loss might use glasses as a way of camouflaging or masking or making it less obvious. And of course, counseling, as we mentioned. There's also some good resources that patients can be directed to, including the National Alopecia Areata Foundation. Let's look in a little more detail at first-line medical therapy, and this is typically corticosteroids. We can use injected mid-potent corticosteroids. This often works well for older teens and young adults. Usually we do this monthly. It can cause some atrophy and hypopigmentation, and it can be painful. We can certainly use some topical anesthetic, although that doesn't completely eliminate the pain. And I would say many young children don't tolerate this, but some do, and of course, as kids get older, this is an option. We can also use ultra-potent topical corticosteroids. Typically, mild, medium, and even potent steroids don't tend to work very well for alopecia areata, so certainly for the scalp, we would stick to ultra-potent, maybe something a little bit milder around the eye. We usually take breaks in therapy. So one example would be to treat once a day to the affected area for 1 month and then take a 1-month break. And the reason we do that is to decrease the risk of atrophy, striae, and absorption. 2 weeks worth of an ultra-potent corticosteroid topically could, in some cases, if the area is broad enough, be enough to lower the HPA axis cortisol production. So it's important to be aware of that and to try to build in breaks to reduce that risk. Patients can also be advised that they may need a stress dose of cortisone if they were to become unwell. If this is not something that falls within your realm of treatment, then certainly referral to dermatology would be appropriate to consider these treatments. There is some role for oral steroids in select cases, often for acute, severe, rapid onset flares. However, while it can work quite well, we often see a rebound as the steroid is stopped or tapered. Of course, side effects of oral steroids can be limiting, and there's no one standard protocol that is used. Second and third line treatments can include things such as topical immunotherapy, minoxidil, which is off-label both for alopecia areata and for children, but there is some evidence to support its use. Oral immune suppression such as methotrexate in severe cases. Some biologic therapies have been tried off-label, and probably the newest class that will hopefully be available soon and is on the horizon are the JAK inhibitors, the Janus kinase inhibitors, which are still by some people used off-label, both orally and topically. Two treatments that I'll talk a little bit more about, just so that you know about them. The immunotherapy that I mentioned on the previous slide is really a very specialized treatment in specialized centers that in a way creates a contact dermatitis by the application of an allergic contactant in a way to try to trick the immune system, where the immune system gets diverted to the dermatitic eruption and seemingly leaves the hair alone. Side effects can include the dermatitis component can be very severe. They can get substantial lymphadenopathy, and the practitioners who apply this substance can actually become sensitized to it. It's really quite specialized and may be hard to find. Minoxidil, which as we said is off-label for alopecia areata and in children, it may work by stimulating the hair follicle DNA. If this is going to be tried, then usually it should have at least a couple of months, assuming it's tolerated, to really know if it's going to work or not. Side effects can include irritation, as any topical product can cause. It can cause increased facial hair growth, and it can actually get absorbed and cause low blood pressure, leading to lightheadedness and dizziness. And if this last one occurs, of course, it should be stopped immediately. Studies have shown that it can contribute to some hair growth in some patients. And of course, counseling. It's important to help families understand that this is a chronic and recurrent condition that we can control and improve flare-ups, but not cure it completely. Hairstyling can help camouflage. Patients can consider wigs. I've given the website here of Locks of Love that can help provide families with wigs, including patients who financially have trouble affording it. And many local wig shops also will have services for children with alopecia areata. Teasing at school can be an issue, and if necessary, then certainly involving the teacher and the administration. And some patients need more than some short-term supportive counseling. They might need more intense psychotherapy, and they can be referred accordingly for this. Let's just quickly review the normal hair growth patterns. We talked about the phases. Growth can be from 2 to 6 or 7 years. The anagen phase on the scalp, shorter in other areas. Then we have catagen, then we have telogen, which is the rest phase where hairs stay for approximately 3 months, and then the hair falls out and the new hair starts to emerge through the base of the follicle and ultimately through the scalp. What this leads to is that at any one point in time, approximately 80 to 90% of scalp hairs will be growing, and about 10 to 15% will be in the rest phase, with subsequently approximately 50 to 150 hairs lost daily and replaced. And this is again just the visual walking you through how the hair is attached, lifts off, rests, and is shed as the new hair emerges. Telogen effluvium is a condition where the ratio of the growth of the hair to resting is changed. And so more hairs are sent into the resting phase, and then these hairs will follow approximately 3 months later. It can range from about 1.5 to 4 months. What can cause this switch from changing the hairs from anagen to telogen? There's both physiologic and pathologic changes. Physiologic can include telogen of the newborn, where we often see babies, newborns shedding their hair, and women postpartum can get a telogen effluvium as well. Many types of illness or psychological stress can also cause this, including surgeries, infections, high fevers, and malnutrition, etc. And these are things that can cause telogen effluvium as part of their presentation. The diffuse shedding in telogen effluvium starts about 1.5 to 4 months after the trigger, and it usually lasts for about 2 to 4 months and then slows down. It can present as shedding or shedding and then thinning of the scalp with a thinning of the hair on the scalp with decreased hair density. It does not lead to complete baldness. The hair pull test is positive, and that's where gently hairs are taken and gently have some traction applied, and you'll see that hairs come out easily. Complete regrowth occurs, which is something that we certainly can reassure our patients about. In terms of working it up, it's important to identify the precipitating factor where possible. So sometimes patients, you'll know they just had a major illness or a surgery. If there's no obvious trigger, consider a workup for occult disease. And we typically would do a CBC, TSH, ferritin, and routine chemistry. Sometimes it's idiopathic. There's no known history and the workup is negative and it's presumed to be idiopathic, or perhaps there was a trigger that was forgotten. There's really no active treatment for this condition. We reassure them and educate them about the condition, and the hair usually starts to regrow after the shedding phase has stopped. However, that's to get the hair to emerge through the scalp. If somebody had very long hair, it will of course take several months or years to be the length of the rest of the hair, depending on that length. Let's look at traumatic alopecia, and this is the removal or breakage of hair from trauma. And there's several subtypes. One is trichotillomania with self-pulling. Another is styling or traction alopecia, where tight ponytails or braids or mechanical devices and heat devices, straightening irons, curling irons, and the pulling on the hair, the tension on that hair as they're being used can lead to hair loss. Pressure, so for example, babies who are sleeping on their back or after post-surgery when somebody's still immobile, these can contribute to that. And then friction, so rubbing or scratching of the scalp, such as in eczema or lice, which we mentioned before. Trichotillomania is a form of traumatic alopecia where patients pluck their own hair. This can be done consciously, subconsciously as a habit, or it can be a manifestation of stress and anxiety. Most patients with this condition are kids, teens, and young adults. The literature suggests a higher proportion of females, although I'm not sure in clinical practice that completely bears out. I certainly see many males with this condition as well. It can include the brows and lashes as well, and sometimes beard and mustache area as well, although the scalp is probably the most common. I've included this in my algorithm when we go back to that under shedding, not because it's a condition with shedding. It's not a condition with shedding, but it's often reported as shedding. And this might be because parents or patients see a pile of hair on a pillow or on the table surface. And also because when pulling isn't disclosed or witnessed, it's not a diagnosis or a suggestion that many families accept readily. And thus, it's often described as shedding. It can lead to an irregular patch of hair loss. You often will have mixed hair growth and areas of hair loss, and this is called moth-eaten, where you see both active hairs, broken hairs, and bald areas. The scalp itself, however, is normal. And here you see that moth-eaten look where some hairs are shorter, some are longer. There's little patches of alopecia mixed with little tufts of hair. And some more examples of that. Management is primarily to start with a supportive physician or healthcare provider-patient relationship. Try to avoid confrontation. Again, this is not a diagnosis that's always accepted so readily. reassurance, acknowledging that this can be subconscious and not blaming the patient, and identify and dealing with the underlying stress if one is present. For more significant anxiety or stress or associated OCD-like behaviors, patients may need a referral to psychiatry. Traction alopecia, which is another type of traumatic alopecia, will lead to thinning, but in a pattern that depends on where the lines of tension are. So with small braids, the areas of thinning or balding can be at the periphery. Often that's where the most tension is applied, or between the braids. With hot combs, the vertex in the periphery of the scalp. With traction alopecia, if it's early, it's often reversible. But if the pattern of traction goes on and on for many, many months or years, it can actually lead to permanent hair loss by destroying the hair follicle. And here you can see some traction alopecia at the periphery from very tightly woven braids. Androgenetic alopecia, what is also known as common baldness, is caused by androgens interacting with receptors on the scalp follicles, and in genetically susceptible people, it results in thinner, finer hair. In the more severe cases, it can lead to partial or full balding as well. This is more common in males than females, and it certainly can start in the teens. One study showed that 15% of boys already had some evidence of this by the age of about 15 to 17. It can run in families or appear in a patient for the first time. The male pattern in children is typical to the adult pattern, which is vertex thinning and bitemporal thinning, and female pattern in teens when this happens is again similar to the adult female version, which tends to be thinning centered around the central part. Teen males, if they've already started puberty, don't usually require a workup. Females may also not require workup, but if there's other suggestions of androgen or endocrinologic abnormalities such as menstrual irregularities, hirsutism, virilism, they may well need a workup or referral to endocrinology. And here we see the common bitemporal pattern in males. And this is an older woman with that prominent central thinning, but it can occur in younger females as well. In terms of managing androgenetic alopecia, again, education is important, supportive counseling, and helping them to understand that it doesn't usually spontaneously resolve, and this can be very distressing for patients. Treatment can include medications, again, off-label usage of minoxidil. In this case, it's not off-label for the condition, but rather the age. And the same application and side effects as we discussed earlier would apply in this indication. Finasteride is not typically used in teens. Anti-androgens may be used in select cases in females. Hair transplants aren't something typically done in the pediatric population, but it might be the option for some of these patients as they move into adulthood. And then, of course, artificial hair, wigs, extensions can be used to increase the visual fullness of the hair. There aren't non-medical or shampoo type products that really help with this. Again, minoxidil can help. There can be a pretty substantial improvement in some patients, but what studies have shown is that patients who get benefit, if they discontinue the treatment within about 6 months, the pattern of hair thinning ends up back where they would have been if they hadn't treated themselves in the first place. Let's look at hair loss that also occurs with scalp disorders. So we talked already about conditions such as atopic dermatitis and lice. If the scalp is very itchy, there can be a secondary frictional alopecia. Psoriasis and seborrheic dermatitis don't classically have hair loss at all. But the one scenario where you might see it in those conditions, and it's quite rare, is there are some versions of psoriasis and seborrheic dermatitis that have very, very, very thick scale, and that's called pityriasis amiantacea. And sometimes hairs become entrapped in that very, very thick scale, and when the scale is lifted off, it removes hair with it, but again, it's from being trapped as opposed to a primary hair loss disorder. Tinea capitis, however, is a disorder that affects both the scalp and the hair shaft. Tinea capitis is common more so in prepubertal than postpubertal children. And the two most common dermatophytes that cause this are trichophyton tonsurans, which is typically transmitted human to human and is less inflammatory, and Microsporum canis, which often can have an animal reservoir and tends to be more inflammatory. Transmission can be person to person, pet to person, from fomites, inanimate objects, and possibly even with shed scale or hairs in the environment. There's two groups of clinical manifestations: the non-inflammatory, which can just be a scaly patch. There may or may not be alopecia. Black dot tinea, where the hair shaft is weakened and it breaks off at the scalp looking like little black dots. Gray patch tinea. It can simply be a mild increase in perceived dandruff, and they may have some non-tender lymphadenopathy. The inflammatory versions tend to have pustules. They may be more likely to have bigger patches of alopecia, crusting erythema, carrion, which are tender, boggy inflammatory masses. They can have tender adenopathy, and this can result in permanent scarring. So here we have a classic patch of partial alopecia, reduced hair growth, and scale. This would be black dot tinea, where some of the hairs have been broken off. This is inflammatory. You can see a dried exudate developing plus alopecia. Here we see just some mild alopecia, although if you were able to rub or scrape the scalp, it would have some scale on it. This is a carrion. You can see that dense inflammatory nodule. And this is scarring alopecia. And the reasons we treat tinea capitis, some people, of course, simply don't like having a scaly or an itchy scalp. It is infectious and contagious, so we want to treat it for that reason. But ultimately, we want to prevent also scarring alopecia, which, while rare, isn't reversible. The differential diagnosis for tinea capitis can include sebderm, atopic dermatitis, alopecia areata, psoriasis, bacterial folliculitis, and trichotillomania. I've quoted a study here, and while it's old, I think it still it holds true very well, which is that alopecia or scale with substantial lymphadenopathy is highly predictive of tinea capitis. And just to show you how it can sometimes be challenging to tell tinea capitis without a culture from the other entities on the differential diagnosis list, here we have seborrheic dermatitis, and here we have tinea, but they can look similar. Here we have psoriasis, and here's tinea, but both of them have this very thick white adherent scale. Here we have trichotillomania and black dot tinea, which can look similar. And here's alopecia areata and scarring alopecia secondary to tinea capitis. And you can see they look similar. So I suggest always sending a culture. And this is true even if you're going to treat on spec. You don't necessarily have to wait for the culture to come back. They can take up to a month. So you may want to treat while awaiting that, particularly if there's evidence of alopecia. But the reason to send a culture is that there's many causes of non-fungal scalp disease, and we've looked at some of those, and it's not always easy to tell them apart, and a culture will certainly help. The other thing is you may want to know which dermatophyte is actually causing the eruption, because the Microsporum species sometimes need longer therapy to clear. And finally, if you treat them with oral therapy and they come back and they're not much better, and you decide at that point to send a culture, you may actually get a false negative because you already have antifungal on board and in some of the hair follicles. Management includes therapy to treat tinea capitis, which we'll talk about in a moment. We want to treat complications. If somebody has a secondary bacterial infection because they've scratched and they've opened their skin and now bacteria have gotten in, or the severe carrion. Data doesn't really support the use of prednisone for carrions, although it's often used clinically. And certainly if there's severe inflammation and your concern is high for permanent alopecia, it may be worthwhile to do a short course of prednisone. And then management to reduce spread within a household. So the use of spore-inhibiting shampoos is not really going to help the tinea capitis itself, but may help decrease spread within a household. Avoid sharing hair care products and clothing, and evaluate close contacts to ensure that they don't have it as well. Therapy is typically oral therapy, and again, microsporum canis may require longer therapy. One study showed that griseofulvin may work better than terbinafine for microsporum canis, but the terbinafine works better for tonsurans. The options, I would say most people or many people will use terbinafine, which is approved for age 4 and above, and I've given you the doses here based on weight. Side effects can include rarely transaminitis, a drop in polymorphs, and taste and alteration, and it interacts with other medications, so make sure to check if the patient's on other medications. There's evidence that itraconazole and fluconazole can work. They too are off-label, and griseofulvin has been used in doses of 10 to 20 milligrams per kilogram per day. I'm showing you here a completely different condition just so that it's on your radar. This is often mistaken for other hair loss problems, so it's important to note it. And this is called temporal triangular alopecia. And it's roughly a triangular pattern on the temporal area that has decreased hair density compared to the rest of the hair, the rest of the scalp. This can be congenital or acquired, and it can be unilateral or bilateral. And sometimes when patients note it, they'll come in and there'll be a concern for alopecia areata or the thinning of androgenetic alopecia, but this is really in the temporal area, not the bifrontal, sort of more of a rounded pattern of hair regression that we'll see in androgenetic alopecia in males. So let's come back to our algorithm here. Let's start with hair that's growing either poorly. Sometimes this is reported as my child never has to get a haircut, or the texture is abnormal, it's rough, or easy breakage. So abnormal growth or texture can present as poor growth or abnormal texture. And when it presents as poor growth or limited haircuts, this might reflect a hair cycle abnormality or a hair shaft abnormality. So the hair shaft abnormalities we talked about are quite rare conditions that can include hair keratin genetic abnormalities. It can include ectodermal dysplasias, and some conditions where the hair shaft is seen under microscopy to be abnormal, but it's NYD without a clear etiology. In terms of hair cycle abnormalities, the most common one is telogen effluvium, which we've talked about, but there's some other rare hair cycle abnormalities, including one called short anagen syndrome and loose anagen syndrome. And these are very rare, but these are conditions where anagen just can't maintain its length of 2 to 7 years. And because it's shorter, patients' hair doesn't grow very long and they don't need haircuts. So just to be aware of that, this can be diagnosed the loose anagen syndrome can be diagnosed with hair shaft analysis, as can some of the hair shaft abnormalities, and this may need referral to dermatology to be able to arrange for that testing. Abnormal hair texture can also be a sign of a hair shaft abnormality. Let's look at the second category, which is shedding, and we divide that into diffuse and localized. Diffuse causes of shedding would be telogen effluvium, which typically occurs all over the scalp, and the rarer form of alopecia areata, which presents as sort of a diffuse shedding with ultimate thinning rather than bald patches. Localized shedding can also occur in alopecia areata in the given round or oval patches before they develop their bald patch. And I've put question mark trichotillomania here because, again, trichotillomania is not primarily a shedding disorder, but it sometimes is reported historically as my child's hair is shedding. I've seen piles of hair. If we look at thinning or decreased hair density, if we start with the diffuse category, again, telogen effluvium, which can be noted at the shedding phase or at the thinning phase. And some hair shaft abnormalities, either genetic or some of the ones that we don't know the cause of, because of abnormal hair shaft itself, there's often less hairs that grow because some of them are so dysfunctional they don't grow. And this can present as diffuse thinning. Localized areas of thinning can be from friction, where there's rubbing back and forth. Sometimes a baby with atopic dermatitis might rub instead of scratching, but both scratching or rubbing can lead to friction with secondary hair loss. traction. So we've shown some patterns before, either hairstyling or those types of things that will leave the thinning in a localized pattern based on the lines of tension. Trichotillomania can be localized. Temporal triangular alopecia, which is a very particular localized form of hair thinning, although not usually complete loss, and I showed you the photo of that. And androgenetic alopecia is localized in very particular patterns that we talked about, and it does differ between males and females. If we look at true full bald patches, this can be diffuse and localized. The diffuse versions of bald patches can include alopecia areata, which can be quite widespread, and tinea capitis can also produce fairly wide areas of hair loss. I had shown you before that picture of the child who ultimately had scarring alopecia over much of their scalp. Localized bald patches can certainly occur from trichotillomania. It is possible to pick a whole area completely clear. The entrapment of hair from conditions such as psoriasis or sebderm, if they get very, very hyperkeratotic and scaly, again, it's not primarily a hair loss disorder, but hairs can get trapped and ultimately come out, and they should regrow. Friction, again, can be so significant it leads to a full bald patch. There's three ways in which birthmarks can create a bald patch. The first is one can actually have a birthmark where there's just a localized patch with very little hair, or the hairs might be so fine it gives the appearance of being bald. A second pattern would be a birthmark or an area where there's a patch of scalp that just never developed hair follicles properly, and that presents as a completely bald patch. And the third would be a birthmark where you actually see a lesion there. And the most prototypical example of that would be a nevus sebaceous, where you actually have a palpable plaque and no hair grows within it. And in the workshop that I'll be presenting as part of this conference, we talk about nevus sebaceous in more detail. Tinea capitis can lead to a much more localized area of baldness as well as more widespread, and of course, alopecia areata. The conditions that are highlighted in pink can often affect both the scalp and the hair, either primarily or secondarily. So hopefully this overview will give you a sense of how to practically divide up patients who come in and present with hair loss. And by looking at the different patterns and presentations and taking your historical clues and what you see on exam, hopefully being able to narrow down to what the actual diagnosis is. And here's one more chart that might be helpful. It's looking at the 5 most common causes of hair loss disorders in children that we've just talked about, and then some of the key features that can help confirm those diagnoses and help you sort them out from one another. So hopefully now at the end, you'll be able to identify the different patterns of and presentations of hair loss in children, be able to initiate a workup to confirm diagnosis and rule out similar looking lesions where indicated, and identify management strategies where relevant for children for the most common causes of hair loss in children. Thank you so much.